Hello everyone, this is Brent Orton, student of KIN353, and today we're going to address the common injuries to the sport of running and what can be done to address it. The methods of injuries and of course the anatomy, as well as the preventative and rehab that goes along with that. So the first injury that's quite common that you all probably know as shin splints, more properly termed medial tibial stress syndrome, or MTSS for short. And this is especially among running athletes, but it can also happen with jumping athletes as well. Any triathlon athletes, it's common as well with them as well. The pain is generally felt on the medial, anterior medial aspect border of the tibia. So in regards to the anatomy, the bone here is in regards to the tibia, which is in the lower leg there. And basically what's happening is there's the periosteum of the bone, which lines the bone, becomes inflamed from the constant tension or pulling from the muscle, which would be the soleus and flexor digitorum longus, but more specifically coming from the soleus. And over time, this can create micro tears or micro trauma to the bone as it starts to pull away from the muscle, which creates the pain that's felt along with many athletes. So mechanism of injury, what can cause this? There's many causes, but as many studies have said that the most common things that they think are causing it are underpronation of the feet, improper footwear. So if you're wearing a pronated shoe that is more suited for a supinated foot, then I guess that would be a big cause, I would think. Tight gastrocnemius and soleus is probably the biggest, as they're finding that the gastrocnemius and the soleus are, like I said previously, the soleus is more specifically the muscle connected with that bone, but the gastrocnemius is close to it as well, so it can trigger it. Malalignment of the hip to ankle, so we're basically just looking at a view from the ankle all the way up to the hip, so as above so below. If we're having issues at the shin bone, it could be something that's going on with the muscles surrounding the knee, or likewise at the ankle. So we need to address and look at those as well. Any abrupt changes in the running program, so going too hard too soon, not periodizing the training, that can all be a big thing causing it. Any abrupt changes in the running surfaces, so if you're running on grass and then switching over to concrete or vice versa, so from soft to hard or hard to soft, that could be a big component as well. And then just poor running technique, biomechanics, so a novice runner versus a professional, obviously there's going to be a difference there, and there's actually studies show that it does happen more frequently in people that are just beginning. And then high body weight, so obviously with the ground reaction forces against the body, with more body weight, there's more weight to transfer to the ground, and vice versa on the way up. So some rehabilitation exercises that are shown to be effective for this. But the first thing we need to distinguish is it a stress fracture or is it MTSS? And if the pain is felt along the tibia that's greater than 5 centimeters, then the chances are pretty certain that it's MTSS. However, if it's localized, then the chances are pretty good that it's a fracture and that needs to be examined further. But X-ray is the only way to really rule that out. Stretching is very critical for the recovery rehabilitation process. So as shown here, standing soleus stretch as well as the standing gastrocnemius stretch would be effective, as the picture shows here. We have a woman here with a straight leg, which would be effective for gastrocnemius, and then bending the knee would be more for the soleus. So you'd want to do both of them. 3 sets, holding 30 seconds to 2 minutes, about 3 times a day and 5 to 6 times per week. Strengthening and range of motion for the arch as well as the plantar flexors, both very important. So towel gathering and resisted dorsiflexion plantar flexion would be great for these. And for towel gathering, 2 to 3 sets, 10 reps, 2 to 3 times a day, 4 times per week. And same follows for resisted dorsiflexion plantar flexion. So you could use anything, so tubing or anything like that, but we're just pumping the gas basically, front and back, to work the both the anterior tibialis as well as the plantar flexors. And 2 to 3 sets, 15 reps of those, 2 to 3 times a day, and 3 to 4 days per week would be optimal for that. Preventative care. So it is critical that the patient continues a daily program of static stretching and range of motion program as the patient returns to their sport and beyond. So again, just emphasizing the importance of stretching. So you want to be making sure to stretch the gastrocnemius and soleus. Again, 3 sets, maybe increasing the time, 1 to 2 minutes, 3 times per day, and 5 to 6 days per week would be good on that one. Range of motion exercises. So here we have pictured just all the anatomical positions of the range of motion of the ankle. And we have dorsiflexion, plantar flexion, eversion and eversion, inversion, and circumduction, making circles with the foot. 2 to 3 sets, if each one, 10 reps each direction, twice a day would be good, and 5 to 6 days per week. And let's see, towel gathering or marble pickup is a common exercise also that's been shown effective. So pictured here is showing someone that's doing that with the towel. And you can also increase the difficulty by putting a weight or something attached at the end of the towel. As someone's scrunching, it's a little bit more resistance. So 2 to 3 sets of that, 10 to 15 reps, twice a day, and 5 to 6 days per week. And finally, myofascial release is very important. So to target the soleus and the gastrocnemius. So a good thing here would be a lacrosse ball or a peanut ball. And 1 to 2 sets, 2 to 5 minutes, 3 times a day, and 5 to 6 days per week. Okay, moving on to the next one, patellofemoral pain. So it's kind of a fancy name for just pain around the kneecap, or just any generalized pain in the knee. It's also known as jumper's knee or runner's knee, and it's just a broad term, like I said, to explain any pain felt at the knee or patella, around the patella. And there was one survey that conveyed that 2002 runners representing to a sport medicine center patellofemoral pain syndrome accounting for 19% of running injuries. So almost 20% of all running injuries are stemming from pain in the knee. So really it's a translation of the patella, and we'll talk about that in the next slide. And then it can also lead to chondromalacia, which is a softening of the cartilage or the bone even, and that's due to the tracking. It can also cause crepitus or cracking, which is very common, and several tests can determine that. And so just continuing here, so looking at the anatomy, so it's basically you have the muscles and the tendons. Well, first of all, we have the femur. It's the upper leg, and then we have the patella, And then we have the trochlear groove that sits right in here where the patella sits, where it should be sliding up and down nice and smoothly as the knee bends and extends. But unfortunately, what happens is because of malalignments, muscles, tendons, ligaments around the patella, that tends to track, or usually it's a lateral tracking, so it pushes that patella outside the trochlear groove, and this can cause the pain. And this is usually due, like I said, to muscular imbalances, typically the anterior thigh and at the hip. And so more specifically, vastus medialis, and usually that's combined with an overactive vastus lateralis, an overly tight iliotibial band, and studies have shown that weak hip abductors and even adductors can be in play here too. So what's causing this? Could be many things, just like the medial tibial stress syndrome, many causes, and its etiology is not really known 100% sure, but some of the things that they're thinking is changes in footwear, changes of ground surface, muscular imbalances, overuse, overloading and training, too soon, too fast, weak quadriceps, like we said, vastus medialis obliquus, weak hip abductors, that's a biggie, overactive hamstrings, so tight hamstrings could be a big one, excess pronation of the foot, and it also could be congenital as well. So going on to the rehabilitation. So it is critical that the patient strengthens all the muscles surrounding at the knee and at the hip as well. So we want to address any overactive muscles, or as well as weak muscles as well. And starting out in the program, you'd want to work from a isometric to an isotonic progression. Most studies are saying that isometric to start out is best. And closed kinetic chain exercises is preferred, especially starting out. And there was one study which I thought was interesting, and it's talking about hip abductors and their importance for strengthening. And they had a significant reduction in pain sooner than those who just worked the quadriceps strengthening. And so here's some of the exercises that would be optimal for this. Seated single leg extension with ball between leg. And I couldn't find a picture for this, but the best thing I could find is something like this. So you're seated, and she doesn't have the ball in between her legs, but she would have that ball in between her legs. And then the patient would invert the foot, so medially, and then she'd want to extend the leg. So as she's pressing the ball in between each of the knees, she'd want to extend the leg. And this really, really concentrates on that VMO and the adductors as well. So moving on to the hip, so a side-lying clam with a loop band or any kind of a band would be good for that. Here's a picture of it right here. And generally, any of these exercises would be very, very effective for this. Working the posterior chain and the abductors. Very important for rehabilitating the knee. And also, not pictured, but side step-ups has also been shown to be effective for this. Just making sure that the knee stays in alignment as you're doing it. And so going back to the first exercise, you want to do 2 sets, 15 reps, 1 to 2 times a day, 3 to 4 days per week. And same applies for the other ones here, except for the difference here with the clams, 15 to 20 reps, and then side step-ups, 10 to 12 reps. Prevention. So it is very important that the patient continues a daily program of VMO and hip abductor strengthening. as well as addressing any overactive muscles such as the IT band, hamstrings, rectus abdominis via dynamic and static stretching program. So some of the exercises that would be good for continuing a rehabilitation preventative program would be hamstring stretching, ITB, as well as RA. That could come in various forms: standing, seated, laying down, etc. 2 sets, 30 seconds to 1 minute, 2-3 times a day, and most days per week, 5 to 6 days per week. And side bridge, side lane leg raise, going back to the previous picture. Those are all very effective for continuing to strengthen those muscles that are weak. 2 sets of 15 on both of those, 1 to 2 times per day, and 3 to 4 days per week on both of those. And myofascial release, so releasing those muscles that are overly active. That would be generally, not always, but generally the ITB, the hamstrings, and the rectus abdominis. So a foam roller or lacrosse ball or some sort would be good for that. 2 sets, 15 reps, 1 to 2 times per day, and 5 to 6 days per week. Actually, I'm sorry, reps, that needs to be changed to time, so I apologize. That's 1 to 2 minutes generally of release time. You can go on up to 5 minutes. It doesn't matter on this one. Okay, so moving on to the last one here. So plantar fasciitis is, well, what is it? So if we break it up, plantar fasciitis. So it's the plantar aspect of the foot, the bottom of the foot, the fascia, and then itis, which is itis is inflammation. And so more specifically, the plantar aponeurosis, which originates from the base of the calcaneus and extends distally to the phalanges of the foot. So typically what it is, it's pain, and it's felt on the medial portion of the calcaneus, but it also can be at the middle of foot as well. And pain and how you know it's plantar fasciitis is it's pain that's worsening in the mornings or any kind of a break in activity. And it's also felt more on a stretch, so foot dorsiflexion. And we'll get into the causes, but this is the main cause here, or one of the main causes: tight plantar flexors, gastrocnemius, and soleus. So common causes, yep. Tight Achilles, heel, and gastrocnemius, as well as soleus. Weakness, so usually it's weakness in the intrinsic muscles of the feet. And improper footwear. Again, if you're wearing a shoe that's more appropriate for a pronated foot, but you're wearing more appropriate for a supinated foot, then that's going to cause some problems, and vice versa. And again, overreaching, overtraining, too soon, too fast can be a cause of this. So rehabilitation for this, it's very critical that the patient continues a daily program of static stretching and range of motion. Yeah, stretching and release techniques are very important for this. So gastrocnemius and soleus stretches are very important, 2 to 3 sets. So you can see a picture here. This lady here is doing a straight leg, working the gastrocnemius. 2 to 3 sets, 30 seconds to 2 minutes, 3 to 4 times per day, and 5 to 6 days per week. Range of motion exercises, again, we're kind of just making sure that range of motion throughout the foot is good. So dorsiflexion, plantar flexion, eversion and inversion, and circumduction. And towel gathering, marble pickup, so this is for the intrinsic muscles of the foot. That would be very good to do. And 2 sets, 10 to 15 reps, 1 to 2 times per day, 5 to 6 days per week. And cross-friction massage, something that you could do sporadically throughout the day, kind of as needed. And 2 sets of anywhere from 5 to 15 minutes. 1 to 2 times a day, 5 to 6 days a week. It's really up to the patient. If they find relief from that, then that would be a good thing to add to the program. So moving on to preventative care. So again, it's very critical that the patient continues a daily program of static stretching, range of motion, myofascial release to help with the recovery and to return the patient to their sport. So it's just a continuation of the stretching, the gastrocnemius and the soleus. Maybe increasing the time would be appropriate here. So 2 to 3 sets, we'll have 1 to 2 minute stretch, 2 to 3 times a day, and most days per week. Range of motion exercises, again, keeping up with that would be important. 2 to 3 sets, 10 reps, and 2 to 3 times a day, 5 to 6 days a week. And continuing with the towel gathering, 2 to 3 sets, 10 reps, 1 to 2 times per day, 5 to 6 days per week. And also trigger point release. There's been one study, actually more than one study, but this one in particular, trigger point release with stretching improves plantar heel pain better than stretching alone, which was an interesting study that I found. So it's very important, they find, to using a technique like this. So a lacrosse ball or something of a hard, or even a tennis ball would work for this. And 1 to 2 sets, 2 to 5 minutes, and 2 to 3 times per day, 5 to 6 days per week would be good for that. Oh, one important note. So when you are stretching for this, you always want to make sure that you're stretching at especially the phalanges, the first phalanges, your toe, your big toe, and then maybe in the opposite direction, pushing on that heel back. So that's what they're finding, is making sure that that toe is back. And that's it. There's the references. And I just want to say thank you for the class, and I really enjoyed it. And that's it. Thank you very much. God bless.